surgery, and what did you think of the Graham Rouse presentation?
I'll tell you what, I've seen it.
Okay.
I understand kind of what you're trying to do with it, but for the GYOs, it seems to be a great tool for the urologist. You've done a lot with it, from what I understand.
Yeah, we are. We're actually on a trajectory, an incredible trajectory as far as adoption and growth. And not only just GYN oncology, but across all malignant specialties. And that's really why I wanted to talk to you as a surgical oncologist to get your perspective. Okay. Not only on robotics, but just surgery in general and how you treat malignant disease.
Well, that's really all I treat.
I know. Exactly.
I'm a cancer guy, so.
Exactly. And so what you're doing right now is exactly what Intuitive's mission is in the marketplace. Our value proposition in the marketplace, Dr. Cohen, is to really partner with those surgeons who are surgically treating malignant disease, but taking that and the benefits of open surgery and the clinical outcomes that are necessary, cancer control probably being one, and really bridging that with a minimally invasive approach. So it's kind of a win-win. And we're seeing a tremendous amount of adoption across multiple specialties for malignant management.
So where would I use it? I do it. All my cases are done open. They kind of have to be. We do solid organ resection.
Right.
I do rectal dissection. I do everything cancer.
Exactly. And so, it's interesting. A lot of surgeons share that perspective too. And I know as a surgical oncologist, you're doing hepatobiliary work, but I'd like to talk a little bit more and literally dive down deeper into that colorectal work that you are doing. I have noticed your name on the board with low anterior resections as well as radial colectomies. And can you share with me your perspective on that? Help me understand where you're coming from with that a little bit more.
Well, my LARs are pretty straightforward. They're all fairly distal tumors. Colorectal guys really don't even want them.
Okay.
And I treat them all kind of the same. I do a TME. Okay. All my patients, I believe in it. I actually helped describe that technique years ago. Mm-hmm. And patients do great. I mean, they're out of the hospital in 5-7 days. Okay. They're back to normal diets very quickly.
Okay. Excellent. So if I understand you correctly, you're having good outcomes, obviously. You've been doing this for 20 years, clearly, and you are the specialist in the area. So when you say patients are doing well, help me understand that a little bit more, because I understand.
Well, they're cancer-free.
They're cancer-free.
There you go, yeah.
Okay.
So that's better than what they were.
Sure.
When they came to see me.
And that's primary goal number one, is control the cancer, rid the cancer, from what I understand. But can you help me understand, so when you're performing your total mesorectal excisions, what's your approach? Are you using any type of laparoscopic approach or hand-assisted, or is it strictly open?
Everything's open.
Do you do any laparoscopy?
Oh, a little bit. I tried it, and it's just not feasible for my cancer cases.
Okay.
Cancer's way too difficult to treat.
Sure.
And I really can't compromise my patients.
Right.
By performing a substandard technique.
No, I understand that. So you believe that laparoscopy is substandard?
It's an open technique. It's a gold standard.
Sure.
Show me in the literature where it's better.
No, I can't do that. I can't make that argument. I do have some compelling data that I could share with you a little bit more, but...
Yeah, I don't know. I'm busy.
Mm-hmm.
Everything I do is open. Patients go home. It's meaningful time.
Right.
I just don't see how this is going to fit.
Well,
what I do. I mean, for the GYN oncologists, I understand. They probably need a little robotic assistance.
Sure.
But not for me.
Let me back up a little bit more, because I'd like to kind of share a bigger perspective with you, because it's not just the GYN oncologist. You also have adoption across multiple specialties, like urologists, urology cancer, for example, prostate cancer. Right now, the Da Vinci robot, what we were able to do is basically transform an open approach, which is cancer control and prostate cancer, and now 85 to almost 90% of all prostatectomies are done through a Da Vinci surgical approach.
Right. Yeah, I've heard the urologists have really taken off with this. Yeah.
So why do you think that adoption occurred with urology specifically?
They have trouble with laparoscopy to begin with. They don't get a lot of training.
Sure.
Man, I could understand that. They're in a tight, small space. I could see how instruments probably don't reach, probably don't fit where they're going. That was traditionally, that's an open procedure.
Exactly.
Yeah.
Very similar probably to the same, or parallel to the same pathway that you're on for the most part. Tight, narrow pelvises, try to get down to tough anatomy, rid the cancer control, preserve nerves, etc.
Yeah, is there anybody using this system for
Da Vinci?
For LARs?
Absolutely.
Really?
Yeah, there really is. And if you want, I can actually show you some pretty compelling information. I've prepared a little graph for you.
I'm-
For
I
low
know
anterior
that
resections,
there's data out there, I understand, but I haven't seen any. Who's doing this?
let me show you real quick. I'll show you kind of a perspective. Okay, this is a little presentation, and just again, overview of what the Da Vinci surgical system is. The Da Vinci surgical system enables surgeons to perform minimally invasive surgery with 3D, high definition, intuitive control of their instruments, and tremor-free wristed, endo-wristed instruments. So essentially, it's like having your hands and your eyes right inside someone's pelvis to get great visualization. But Dr. Cohen, if I could bring to your attention, you asked me who's doing robotics. Did you know that in the state of California there are over 103 Da Vinci robotic systems installed here in the state alone?
No, I did not know that.
Yeah, it's pretty
Wow.
compelling. That's why I want to show this to you. And it's a little colorful, but 103 in California, 85 in Texas, 94 in Florida. And this continues to grow tremendously. And we're seeing this trajectory, like I mentioned before, both not on a domestic but also an international level, across multiple specialties. And again, that's why you see the urologist adopted it, because it enabled them to perform cancer-controlling procedures, but it also upgrade, if you will, the patient's quality of life to minimally invasive. You're seeing that adoption now in GYO, but you know who's really leading this charge? Colorectal surgeons.
Really? Is that a fact?
Yeah, it is, and I'd like to share with you a little bit more. But before I do, can you kind of share with me your perspective on colorectal surgery? Because from what you told me before, you're performing open surgery. And what I've talked to other colorectal surgeons and surgical oncologists like yourselves, they like having their hand deep in the pelvis.
Well, yeah, I can feel the tumor.
You can feel it,
Yeah.
absolutely. And obviously, you want to get beyond it, get good margins, healthy tissue for your anastomosis. And but you mentioned also your patients, but we didn't talk about quality of life for your patients. What's it like for your patients? Obviously, they're cancer-free, which is great. That's why they're coming to see you. You're saving their life. But what's that quality of life like for them when they go home?
They have a fairly long recovery.
Okay.
Most of them are obese. Yeah, they stay in the hospital a while. I can only
Sure.
imagine that they're uncomfortable for a couple days.
Right.
But that subsides. It's a midline incision.
Okay.
Most of them, they recover very well.
Good. Well, that's great. Absolutely. But so I'm wondering if maybe you can help me, keep your mind open to maybe a potentially better way. Now, there's hand-assisted laparoscopy. When we talked about laparoscopy, it's strictly limited. It's like operating with chopsticks. It's a very specific, elite few surgeons can actually perform laparoscopic total mesorectal excisions, and the data is not very strong to support it. But Da Vinci, we're seeing a significant amount of adoption because surgeons, again, they want the benefits of open. They'd like to offer minimally invasive, and we're seeing that in both colectomies and also rectal. But there are limitations. Your peers, clearly, the gold standard total mesorectal excision is performed 90% open right now. But we are seeing that growth. You mentioned, show me that a little bit more. So you're seeing a significant amount of growth, and that's 30% growth for colorectal surgeons leading this charge.
Wow.
So, and it's not just total mesorectal excisions deep in the pelvis, it's also colon work too. And I know you do both, which is why I wanted to kind of share this with you a little bit. Low anterior sections, do you perform EPRs?
When needed.
Okay.
Yeah.
When it's really, really low?
When those tumors are mesoplastic anal words, they're getting up EPR.
Yeah, I understand
But,
that. I just heard from a surgeon, Dr. Paradavila. I don't know if you know him. He's down at Celebration, Florida.
I've heard of him.
Okay. He's actually leading this brigade, if you will, because what he's able to do, his big thing is sphincter saving, or sphincter preserving for the patients, enabling them to retain the anus and have a better quality of life. And I'd like to maybe talk to you a little bit about that some more. But you should show me the data. I haven't seen the data. And that's what this is right here. This is a compendium of multiple studies. I just want to bring this to your attention real quickly. Clinical outcomes, Da Vinci versus open in comparison to laparoscopy. Okay, you can look at it three different ways. Let's eliminate laparoscopy right now because we both know that laparoscopic surgery is extremely limited. Guys like Dr. Bake, Dr. Bagazi, even Dr. Park out of University of Maryland. I'll bring this to your attention. Yeah, the patient population.
He's doing this?
He is. Absolutely. Right down the street here in California at City of Hope.
Wow, I trained him.
You did?
Yeah.
Well, maybe you
He's a
two
great
should have a
surgeon.
conversation because let me tell you about the work he's doing with the Da Vinci robot. You can see right here, he's able to receive a positive margin rate of 0%. That's the gold standard. Anything less than that?
I would agree.
For my mom, if I sent my mom to Dr. Big, I'd
How many
want...
patients was that? Out of 39?
39%, yeah. And this
Yeah,
is the
39.
problem with the data with regards to colorectal malignancy. There's not a lot of strong data out there to support
Mhm.
it.